My name is Emma. I'm a third-year medical student in New Mexico. I go to Burrell College of Osteopathic Medicine. So this is Motivate MD's kind of rendition of e-shadowing virtual rounds. As you probably all know, it's very hard to get shadowing now. I know that firsthand myself. It's hard to get rotations even. So this is going to be our first one. We hope it is going to kind of grow over time. We're also happy to have kind of a small group as well. It certainly allows for certainly allows for a lot of interaction between you guys and me. Education and teaching is something that I enjoy myself, even at the level that I'm at. To answer the last question, is it certified by AAMC in medical schools? Not yet necessarily, but the thing about it is it can be something that you can certainly talk about in your applications. So regardless of whether AAMC and medical schools say, yes, we're going to count this, it is going to be a good opportunity you can talk about in your applications. So hopefully that answers your question. Thanks everybody for being here. Today we're going to talk about gastrointestinal bleeding, so GI bleeding. If you guys are not familiar with it, that's totally okay. Hopefully you guys can learn something today. And then if you guys have any questions at all, feel free to you can raise your hand using the Zoom function, or you can throw something in the chat. And if I miss it, Becca, of whom a lot of you have probably talked to, she's also here kind of in the background. Sorry to put you on blast, Becca. She's back there, so she's going to help kind of moderate the chat, and she'll let me know if there's any questions or anything. So feel free to interact. That's kind of my goal. That's what I want you guys to really do tonight. So that way you guys get something out of this. I don't want you to sit kind of there with your Netflix on in the background. I want you guys to kind of interact and learn something. Okay. So with that being said, let's move on here. All right, so I added this slide as the first one. If any of you work clinically so far, even if you were volunteering or scribes in the ER, you probably know what a GI bleed smells like, just the same way you know what C. diff smells like. So I had to add this in, and I hopefully you guys will remember this if you haven't smelled a GI bleed later on. When you have smelled one, you're going to remember this slide for sure, and you're going to remember the smell for sure. Okay, so in terms of the kind of outline for this evening, what we're going to do really is we're going to go through a case. We're going to talk about the physical exam. We're going to talk about the differential diagnosis. We're going to go through the assessment and plan, and we're going to talk a little bit about the pathology. I've simplified this, as much as I can. If there's something you guys don't understand or something that's not clear, let me know. I'd be happy to explain it to you. And so your guys' role, what I want you guys to do, there's a little, it's in the chat also. If you scroll all the way up, I put the link to this form, this Google form. And what you're going to kind of do throughout the session is to, Becca just put it into the chat. What you're going to do is kind of document in a SOAP note form. And hopefully our goal for you is that this kind of formatting, this kind of activity to be able to write things out is going to help you. For those of you that are scribes, you might be familiar with this, and hopefully this will help really prepare you. And then kind of as a reminder, we do have a drawing for these sessions for a free Motivate MD package. So hopefully, and probably some of you guys have used our other services. And hopefully that can be an asset to you in the future. So here's the form as well. So what we're going to do, and it's pretty self-explanatory. The subjective is kind of really the HPI and the ROS. Objective, we're going to talk about the physical exam. The A is for assessment. We're going to go through that as well. And then the P is for plan. And we're going to talk about how to manage a GI bleed. Does anybody have any questions before we kind of move on? You can throw them in the chat. So without further ado, let's get into our first case here. So A 44-year-old female with a past medical history of rheumatoid arthritis, that's what RA is. By the way, I bolded these things, not because I don't know how to use the functions, but because I'm giving you a little bit of clues. So pay attention to these things, be meticulous about those things in particular. So this is a 44-year-old female with a past medical history of rheumatoid arthritis. She presents to the ED with a 2-day history of hematemesis. Hematemesis means throwing up blood. She notes that she has had 3 episodes of vomiting cupfuls of blood. Additionally, she states that her stools have been darker than usual, but thought it was due to taking Pepto over the course of the week. She has been eating less due to having a decreased appetite, but generally eating makes her abdominal pain better. Daily medications include lisinopril, that's for her blood pressure. That's a angiotensin converting enzyme inhibitor, and celecoxib. That's a fancy ibuprofen, basically. PRN, which means as needed for pain. No dizziness, no headache, no weight loss, no syncope, no chest pain, no shortness of breath, no surgeries in the past, no previous episodes of GI bleeding. So keep all that in mind, kind of document what you need into your SOAP note form. So questions that we want to consider here. At this point, number one, what we want to consider is what is significant about her GI bleeding currently? So what is kind of the bleeding pattern or the history that we know thus far? What does that really tell her about, or tell us about her GI bleed specifically? So somebody, you can unmute yourself or you can throw something in the chat, but let me know what do you think? What does this pattern suggest about her GI bleeding? So we know that she has a little bit of, good. So Zena, I hope I didn't butcher that, or Zena, perfect. So why do we think it's a GI bleed or an upper GI bleed? Zena, do you know? You knew it was an upper GI bleed. Oh, okay, yeah, of course I can repeat it. So why do we think it is an upper GI bleed? You're absolutely right. The pattern that we've seen thus far does look like an upper GI bleed. Why do we think that that is the case? Good, good. So she had indicated that she's experiencing hematemesis. That's perfect. She's vomiting up cupfuls of blood. That tells us hematemesis. The 2 different things that we want to consider are hematemesis, that's vomiting up cupfuls of blood or vomiting up blood, versus coffee ground emesis. And that kind of sounds exactly, or is exactly what it sounds like. You know, when you make your coffee and you look at the coffee grounds when they're in the filter, that's really what that vomit looks like. And that kind of just means a little bit of digested blood. And in this instance, what we're getting is cupfuls of blood. So you're exactly right. Vomiting up that blood that looks like blood indicates that it's coming from the upper side. Whereas if she were to have melena, she's indicated that her stools were a little bit darker. We don't know, maybe it is melena, maybe it's not. She was taking Pepto before. If she was having those dark tarry stools, we would say, okay, maybe this is digested blood. But you're absolutely right, perfect. So the next question we want to kind of consider here is, what does her past medical history suggest? That was one of those elements that I bolded there. And anybody else, tell me, what does her past medical history suggest? Or, you know, what did I tell you in the case, or what did the patient tell you in the case that might indicate that maybe she is having a upper GI bleed, or maybe what is the source? Good, throwing up blood. What else? What about her past medical history? Her medical problems, 2 days of bleeding. Good, good, Jonathan. Anybody else? There was a medical condition that was mentioned in the vignette of which might suggest where this came from. Perfect. RA, somebody said RA, and perfect. Why does RA kind of tip us off maybe to bleeding? Was there a specific medication she was taking? What might be really going on here? But RA is exactly right. So there was a medication that she was taking, the celecoxib. I don't know if you guys remember that. It was like a fancy ibuprofen. It is a COX-2 inhibitor. And if you guys remember, or if you know, using NSAIDs, non-steroidal anti-inflammatory drugs, are certainly a risk factor for bleeding because they inhibit prostaglandins. That's a hormone of which helps to produce mucus in your stomach. So if we're inhibiting that production of mucus, then we're more prone to having those ulcerations in your stomach or your duodenum or other parts of your intestine. So good job pointing out the rheumatoid arthritis there. So let's talk about risk factors for GI bleeding. Who knows what some risk factors of GI bleeding are? Throw any out there that you think. Don't be afraid of being wrong. I've been wrong a billion times, and it hasn't hindered me thus far. So throw something out there. What do you guys think are risk factors for GI bleeding? Upper or lower GI bleeding? You can name any of them. Okay, black bowel movements. Jonathan said, perfect. What about risk factors? Smoking, perfect. Good. I think some of you guys work in the healthcare field. What else? Other than smoking, good. There's another one that's a bad habit that can contribute to GI bleeding. Peptic ulcers, okay. What causes the peptic ulcers? NSAIDs, good, perfect. Alcoholism, perfect, Isaiah, good job. So yeah, alcoholism, absolutely. So all of those things that you guys mentioned, absolutely. Do you guys know what is more common, upper GI bleeds or lower GI bleeds? Take a guess. Upper, absolutely, good. Good, you guys are all right. Upper GI bleeds are most definitely more common. If you were to even just know that somebody is having an upper GI bleed and your attending says, you know, is this an upper or a lower GI bleed? Your best odds are saying upper GI bleed. Even with older patients. That leads me to another point. Another risk factor for GI bleeding is older age. And then in terms of medications, other things we can consider in addition to NSAIDs like ibuprofen, which inhibit the production of the prostaglandins like we talked about before, is anticoagulants. So, you know, if someone's on warfarin because they have AFib, or if they're on warfarin or any other anticoagulant because they're more prone to clotting. Obviously, the sort of trade-off with that, you're preventing the clotting, but you're also increasing the risk that they could bleed. So those are a few of the risk factors there. You know, there's other sort of pathologies. We'll get to those at the end. Those are also risk factors, but we'll leave it at that for now. So what are the two types of GI bleeds we can consider? We've definitely answered this already. So that's the upper GI bleeds or the lower GI bleeds. So, and that's the two ways we kind of delineate the pathologies between them. It sounds simple, but it's a lot more complex than that. All right, so what else should we ask her? What else do we need to ask this 44-year-old woman? You guys give me some suggestions. What do you think? What else should we ask her in order to get more information, to get more history about what's going on? Family history, sure. What do we want to ask her about her family history? Anybody else? What else should we ask her? Okay, good. if this is common in her parents. Good. Yeah, there are some conditions like AV malformations of which, you know, they could indicate that something else is going on. Activities of daily living. Does she drink? Perfect. Yeah, we want to ask her social history. Does she drink? Does she smoke? If she does do those things, how much does she drink and smoke? Perfect. Somebody else said substance and alcohol use. Perfect. Those are all good things to ask. What else? What else should we ask her? Yeah, good. Has she lost any weight? What is her current intake? Good. She may be at risk of malnutrition. Absolutely right. And we want to know also when is the last time she did eat. So those are all good points, especially if we're considering any sort of surgical intervention. It's always good to know when is the last time she ate, so that she wouldn't be at risk for aspiration if we were to intubate her and mechanically ventilate her. So good. Anything else? Does anybody else have anything else to add in terms of this? Anything else we should ask her? All right. So good job with that, guys. Thanks for the participation. I certainly appreciate that. So here is our physical exam. So her temperature is 98.6. It looks like she's tachycardic at 110. Her blood pressure is 101/66, and her respirations are 22. So somebody in the chat, let's talk physiology. Why is she tachycardic, but her blood pressure is low? I'll give you guys some time to type that out. But other than this, her general appearance, she is lethargic, but appears her stated age. She is tachycardic as kind of shown in her vitals. She's regular rate and rhythm without, or not regular rate, she's tachycardic, obviously. She is regular rhythm without murmurs, rubs, or gallops. She has 2+ pulses in her radial and dorsalis pedis pulses. So anybody out there, let me know why is her heart rate up, but her blood pressure is down? Other than that, her lungs are clear to auscultation bilaterally. That's what CTA means, without wheezes, rales, or rhonchi. Blood pumping issues, close. So yeah, keep along those same lines. We are talking circulatory. So her heart rate is increasing. We know that she might be bleeding. So what are you guys thinking in terms of that? So her heart rate is going up. Less blood travels to the heart muscle. You guys are getting warmer here for sure. Anybody else? What are you guys thinking? So her heart rate's going up. We know that she's bleeding. Not much blood to pump out. That's absolutely true. And Jonathan, you're on the right track, and I'll tell you why. And that's because her heart rate is going to increase to compensate for the fact that she's losing blood. So if her blood pressure is low, the pressure is kind of telling us that that basically she is losing blood. So the heart rate in the heart is going to compensate by beating faster in order to get blood to where it needs to go. Because all the two most vital organs obviously are our heart and our brain. So we don't want to risk being ischemic, losing blood flow, any of those things to any of our tissues. And so the heart is going to compensate as a result. So you guys are right on the right track. So great job. Her abdomen is soft without masses. She has a little bit of tenderness to palpation in her epigastrium. So that tells us, maybe there's something going on with her esophagus, her stomach. If we think about the organs that are there, I know you guys might have taken anatomy already. She does have some conjunctival pallor. The way we like to look at this is by, either looking in the mouth or looking in your eye. So if you pull down that anterior rim, mine looks nice and pink, a little bit red. In this woman, probably not if she's bleeding. And that's how we want to look too. And that's such an easy way to look to see if she has lost blood, which obviously she has. She's telling us she's vomiting blood. She has minimal skin tinting, and what skin tinting is you pull up the skin and it kind of just stays there. That indicates that she might be a little bit dehydrated. Other than this, for GI, she has a guaiac positive stool and dark tarry stool in the rectal vault without hemorrhoids or anal fissures. So let's go on here. So these are the labs that we have thus far. So I gave you 2 labs, and you'll see here in the upper right-hand corner, there is a, because you're going to see these little diagrams. I always wish that I saw these before I got into medical school, because, you know, I worked in the lab for 2 years at Johns Hopkins, and I never used these, even in the lab. So this is kind of a clinical thing for sure. If you guys have seen these thus far, you're definitely in a good spot. So the key is kind of in the upper left-hand corner. It also gives you kind of the normal values as well. So let's start on the left-hand side of the screen. The first value that we're given is her sodium. That's normal at 137. Her potassium is 4.1, also normal. Her chloride is 101. Her CO2 is 23. So it looks like her she's sort of balanced in terms of those electrolytes, which is great. Her BUN is elevated at 33. As we can see, the normal is 8 to 21. The reference ranges kind of change based on the lab, but this is one that I found. It generally tends to be around the same values. The creatinine is 2.1, and her glucose is a little bit elevated as well. So before we go on to the CBC, tell me about the electrolytes, guys. Why is the BUN and the creatinine, those 2 labs that we look at for your kidneys, that we look at for the renal function, why would those 2 things be elevated in somebody who's bleeding? Anybody have any ideas for that? While you guys think about that, I'm going to expect an answer like last time, but while you guys think about that, let's go on to the CBC. Creatinine signals kidney function, so our kidneys aren't working properly. Absolutely. And why might not they be working properly? What might be going on here? We know that she's bleeding. So how do we kind of connect the bleeding with the kidney function here? Give me some of your guys' other ideas. Other than this, it looks like her white blood cell count is normal. Less blood to the kidneys, ischemia, potentially, yes. Anything else? Other than that, the hemoglobin is 6.4. That is low. That is very low. We start to think about transfusing patients when they're less than 7. And then you can kind of see at the bottom there, I gave you a little definition. Hemoglobin is the amount of protein that carries oxygen. So as you might remember from your anatomy and physiology class, the red blood cell is that biconcave disc that can bind 4 oxygen molecules. And it's important because it carries oxygen everywhere. Digested blood is the source of urea. Jonathan, well done. That is perfect. That is exactly right. And so the blood urea nitrogen, the BUN, is going to increase because blood does have that source of urea. Perfect. Good job. That's exactly what I was looking for. Everyone else who answered, you were right on the same track. Ischemia is certainly a cause. We would look at the lactate too to see if there's causes of ischemia also. Our other value that we're given that is low is the hematocrit. That is at 18.9. Those are both low. The hematocrit is the percentage of the blood that the percent of the blood sample that was red blood cells. So basically the way we measure that is you spin it down, you look at the part of the blood, and you look at the part of the plasma, and it's just a percentage. Okay, so obviously we see here that this patient is very anemic. She has a history. Would you rule out kidney failure here? We would certainly want to, we can certainly get her GFR and see what her kidney function is in terms of that. That's a good question. And we can kind of put it in context too, to see if she's producing urine as well. It's a good way to kind of gauge how well the kidneys are doing. So yes, we certainly want to take everything into consideration. And that's the nice thing about internal medicine. That's why I love internal medicine, is you have to really take into consideration the big picture. We know she's vomiting blood, but we do have to look at the kidneys. We have to look at everything and make sure, everything's functioning okay. Other than this, the red blood cell count is 2.51. That's low as well. As you can see, it's it should be around 4 to 6. For women, about 4 to 5. And then the other value that's low is the MCV. That's the mean corpuscular volume. That tells us it should usually be around 80 to 100. It is low. It tells us that the size of our red blood cells are fairly small. Okay. Any questions about these lab results? Hopefully that all makes sense. I know lab results can be kind of tedious. Oh, other than this, her fecal occult blood test to test for blood in her stool was positive, but we probably already knew that, given that she had black tarry stool in her rectal vault. Okay, so the same way that you guys kind of marked your location in the country, I want you to vote on this. I want you to tell me, on the left side, put your mark. Is it abnormal or normal on the left side, abnormal on the other side? Tell me, is this chest X-ray abnormal or normal? I'll give you guys a few minutes to vote on this. Oh, I like the green one. Whoever did that, let's see. I don't know. Okay. You guys are all going to be radiologists. Okay, Jonathan says in the chat it's a normal chest X-ray. Anybody else? Anybody want to venture to say it's abnormal? No, nobody wants to say it's abnormal. Okay, so I agree with all you guys. Thank you for everybody who voted. So this isn't a normal chest X-ray. You guys are absolutely right. And I'll tell you the way that I kind of look at a chest X-ray. I don't wait for the radiologist to read it. That's a nice way to do it. But you want to look at yourself sometimes. And I encourage you to do that whenever you're shadowing, whenever you're back out in the clinics, whenever you become a medical student. I encourage you to do this. So the first thing that you want to do, the way I do it, is airway. I look at the airway and look at the trachea. Here, let me get a pointer. Never mind. Can you guys? Hopefully you guys can see my cursor. So here's your airway. You want to look at the trachea to make sure it's not shifted either way. B, you want to look at the bones. So let's look at the ribs and make sure that we can see enough ribs. And the way that you do that is by counting these ribs to make sure they have a good respiratory effort. That's the way you can tell a good chest X-ray. C, cardiac. So by the way, this is fairly easy. It's just A, B, C, D, E. So C, we're on C. We want to look at the cardiac silhouette, and so that's what we're looking at here. And it should be not too large, it shouldn't be too small. It should be less than 2/3 the size of the whole span of the lungs. D, diaphragm. You want to look at the diaphragm. Somebody tell me, while we're talking about the diaphragm, why is this diaphragm higher on this side over here? This would be the patient's right side. Why is this diaphragm higher? Somebody give me an answer for that. I'm going to keep going because of blood flow. Anybody else? What's on this side? So this diaphragm looks a little bit higher than this left one over here. Why do we think that? And then the E in A, B, C, D, E is everything else. So you want to look at everything else, and then that's kind of a cop out. The E is everything else. But and then another question I have for you guys, other than why this diaphragm is higher, think about your anatomy. What's on this side here? We know that the patient looks like it's the patient is facing us. So this would be her right side, and this would be her left side. So anatomically, what is on the right side there that we want to think about? Perfect, Zena, perfect. That the liver is there. So that's why one diaphragm is a little bit higher, it appears, because it rests right on top of that liver there. And then my other question for you guys is what is this? What's going on here? And how can we tell if the patient is standing upright? Anybody have ideas for that? We know, yeah, gastric, perfect. And that's exactly what that is that's gas. And that's how we can tell. Sometimes patients are too sick to stand up for upright chest x-rays. And so they might be laying down. So we may not see this gas pattern. And we might, inadvertently tell that they were laying down when they took this chest x-ray. But otherwise, if you're standing up, that air should naturally rise in your intestines, in your gastric region. Perfect. Okay, so let me clear all this and we will move on. Okay, so in terms of our differential diagnosis, the things that we want to consider is obviously whether it's an upper or a lower GI bleed. Due to the symptoms that we've kind of gotten thus far, we as we kind of talked about before, this is definitely an upper GI bleed due to the fact that her blood is bright red. She does have some melena, which means that she's digesting some blood and it's coming out the other end. But the things and really the causes that we want to consider in an upper GI bleed are multiple. So peptic ulcer disease, that's what PUD is. Somebody tell me why peptic ulcer disease, we want to consider that high kind of on our differential diagnosis for this patient specifically. Thinking back to her past medical history, thinking back to the medications she takes, why do we think peptic ulcer disease is common? Or likely rather. Other than this, we have gastritis, epigastric pain, good. She said it was alleviated with eating, good. So the other thing that we want to consider is where the, when you did the physical exam, it was tender, good. The other thing that we want to consider is, the other thing that we want to consider is where the ulcer may be if we are considering peptic ulcer disease. We can have an ulcer in the stomach. We can have an ulcer in the duodenum. As Zena kind of mentioned, the pain is alleviated with eating. And that tells us two different things. If it's a gastric ulcer, meaning that ulcer is in the stomach, the pain is going to be worse with eating. Whereas if the ulcer is in the duodenum, the pain is going to be decreased with eating. The way I always remembered it is duodenum decreased with eating. And that's because the food is generally alkaline, and so it helps relieve that sort of acidic nature. And when we're talking about peptic ulcer disease, because of the NSAIDs, as we kind of talked about before, she's taking NSAIDs because she has a history of rheumatoid arthritis, she has joint pains, and she takes NSAIDs likely like they're candy because her joints hurt so badly, and she takes them so often that the mucosal defenses of the stomach or the duodenum are decreased. Our next one that we want to consider is gastritis. That's similar in sort of etiology. Another thing that we can consider for gastritis is viral causes, bacterial causes. We can talk about cocaine can also cause gastritis as well. It causes like punctate hemorrhages in the stomach. The other thing is epistaxis, so nosebleeds. It's so common that people often forget about it if they've had, a nosebleed or a history of nosebleeds. The other thing is variceal bleeding. We talked about before, we want to ask her if she drinks alcohol. Absolutely. And does anybody know really what's causing these varices to form either in your esophagus or rectal varices or anywhere else in the body? Sometimes in cirrhotic patients, we see them right on the belly. Do you guys know why this happens in patients, why they get variceal bleeding or why they get varices in the first place? I'll give you guys a second for that. Liver failure. Good. So what happens is basically, I'm gonna draw you guys a picture. It may turn out absolutely terrible, but we'll see. Oh, I would choose blue. Okay, here. So here's our liver here. And there's a series of vessels that come off the liver. And what happens when you get, here's the my rendition of the esophagus. And so what happens basically is you get cirrhosis. And so you get scarring of your liver when you insult it over time, whether that's due to hepatitis, whether that's due to alcohol, whatever the case may be. So we're getting scarring here. And what happens is that affects the portal veins, and inevitably that blood starts to back up to these veins that connect to the esophagus. And so what we start to see here are those veins start to balloon up and start to cause those varices. So Zena, you're absolutely right. That's exactly what happens because of liver failure, because of the portal hypertension and the increased pressure in the portal vein. We get sort of reflux of blood that causes those veins in the esophagus to balloon out, and that can cause a life-threatening hemorrhage. And so it's incredibly important to manage that. I don't know if that drawing helped. It looks pretty horrible now that I look back at it, but hopefully it wasn't that bad. The other things that we want to consider are Mallory-Weiss tears. That's a superficial tear to part of the mucosa of the esophagus. This happens to people of whom are vomiting. That it might be somebody who, they go out with their friends and they drink, and then now they're sick, and then they start to vomit. The other thing is Boerhaave. Those are very similar. Mallory-Weiss is superficial. Boerhaave syndrome is a longitudinal tear throughout the entire esophagus. That's a life-threatening emergency as well, because as you can imagine, if your esophagus tears, you're going to get blood or you're going to get blood obviously, but you're going to get air in the mediastinum. And so when you press on these people's chests, it kind of sounds like Rice Krispies. We call it Hammond's Crunch. The next thing that we want to consider is erosive esophagitis. The two big pills that we look for is one called bisphosphonates. Patients take those for osteoporosis. They're like a big pill, and what we tell patients is when you take this pill, you have to take it with a full glass of water and you have to sit upright for at least 30 minutes. And that's the instructions that we give for patients who are taking those pills, because it's so important. Because if you get a pill stuck in your throat or in your esophagus, it's going to burn through that sensitive mucosa. The other pill is iron pills, and then ingestions. Sometimes, unfortunately, we see patients of whom have consumed caustic things. Like I've heard of a patient drinking Drano, which is obviously going to cause a lot of corrosion to that very sensitive mucosa. And then in terms of lower GI bleed, we know that this is less likely because the patients usually will present with bright red blood per rectum. That's what BRBPR stands for. And those people usually have, external hemorrhoids, internal hemorrhoids, ulcerative colitis. They can have diverticulosis with that little outpouching. We'll talk about all those a little bit as we go on as well. Okay, so let's talk about the assessment and plan. So somebody tell me what our diagnosis is. What are we putting our money on if we had to give our 44-year-old woman a diagnosis? You guys know it. I know you do. What are we calling her? Yeah, good, Sadie. That's the first time I've heard from Sadie. There she comes in clutch with the diagnosis at the end. Upper GI bleed, you're absolutely right. Good. So, perfect. Upper GI bleed, and we're calling this secondary to chronic NSAID use. We know that she has that history of rheumatoid arthritis, and we know that using NSAIDs decrease that prostaglandin production, which helps make mucus or the mucus for the duodenum and the stomach as well. So what we want to do in terms of our plan for her is we want to give 2 large bore IVs. We want to put those in for those of you that have experience, either being ER techs or whatever the case is. 2 large bore IVs are 18 gauges or bigger. And that's because if this patient is that sick and she has a hemoglobin in the 6s, we want to give her blood as soon as we can. Other than that, we want to give her IV fluids. We want to give her IV proton pump inhibitors because she has a lot of acid in her stomach. Always in very sick patients, we want to give them proton pump inhibitors while they're in the hospital to decrease their chance of having ulcers while they're in the hospital because they're sick. And that's often how you get stomach ulcers, is not by prophylaxing for it. Other than that, we want to type and cross her. We want to get her blood type and get across also and transfuse 2 units of matched blood. Other than that, we want to trend her H&H. Somebody tell me, why are we watching her hemoglobin and hematocrit? We gave her blood. Why do we care what's going on? Other than this, we want to consult GI. We want to call how the kidneys react. Good idea. What else, guys? Why else are we going to watch this hemoglobin and hematocrit? It was terribly low. She had a hemoglobin in the 6s. She had a hematocrit in the 18s. Why are we watching this? So we're gonna consult GI for possibly an EGD. We might do an NG lavage, that's nasogastric lavage. We could stick a tube down into her stomach, through her nose to her stomach. And lavage means put in some normal saline and suck it up and see what we get, see if she's still bleeding. A lot of times the GI bleeds, the upper GI bleeds will often stop on their own. Sometimes they won't. So GI might have to call surgery, especially if this is a duodenal ulcer, as we kind of signified, an upper GI bleed. We'll want to maybe consult surgery, because if there's that ulcer there, obviously it's causing some bleeding by eroding into that artery there. But if that has eroded into the artery and inevitably caused a perforation, that's going to lead to a lot of free air in the belly, and that's a surgical emergency. So we would have to call surgery for that. Other than that, we might do a colonoscopy as well. A lot of times they do a colonoscopy to rule out bleeding. Other tests we can do are angiography, where we look at the blood vessels to see where it might be bleeding, or a tagged red blood cell study, where we tag the blood and see where it's bleeding out of. So back to my question, why are we trending that H&H, guys? Other than that, we're going to hold the DVT prophylaxis. That means we're not going to give her anticoagulants. For the prophylaxis for PPIs, we often give people who are sick and in the hospital and going to sit in their bed, we often give them DVT prophylaxis to prevent them from bleeding while they're sitting there sick. So you guys are off the hook, I guess. For the H&H, we're going to trend it to make sure it's coming up. Good. For reactions also, perfect. But we also want to watch that H&H to make sure it's going up, because we know that if we're giving her blood, that her hemoglobin and hematocrit should be increasing incrementally, hopefully. If it's not improving, she might be having a brisk bleed and bleeding faster than we can kind of replace this. If we have variceal bleeding, as we kind of talked about, if we have portal hypertension, liver cirrhosis, what we want to do is give octreotide. That's a drug that's going to kind of clamp down on the splanchnic vasculature, all those vessels that go to the GI system, so that there's not as much bleeding. And then the other thing that we want to do is give antibiotics, because if this is a person in liver failure, they're at risk for spontaneous bacterial peritonitis, which is a very, very serious infection of the ascites fluid in people of whom have cirrhosis and ascites. Okay, so the next thing that we want to consider, obviously she has the upper GI bleed, but we want to manage her other conditions as well. And you'll start to learn this as you go along. We want to manage everything. We don't just say, okay, she's GI bleeding, we're going to handle this. We have to handle her other problems as well. So if you remember, she does have rheumatoid arthritis. So we want to stop her NSAIDs. Why are we stopping her NSAIDs? She has pain, right? Why don't we just keep giving her NSAIDs? Somebody give me an answer for that one. Other than this, we're stopping her NSAIDs, and somebody out there is going to tell me why we're doing that. And we're going to consider starting methotrexate maybe for symptom control for her rheumatoid arthritis. Good, yeah. It depleted the mucus in the intestine. Absolutely right. They're the reason for her GI bleed. Try to not make her symptoms worse. Absolutely. Those are all great things. Good job. You guys all said very similar things, different ways. Then in terms of her hypertension, we're going to have to manage that as well, even though the thing about it is this says continue home meds. We might hold her lisinopril even for a minute or for a little while, because if we remember, her blood pressure was low because she's bleeding. She's kind of depleted her vascular volume. So we might even hold that lisinopril so we don't tank her blood pressure and end up stroking her out, basically. Okay, so we're going to go into talking about some of the pathology here. If you guys have any questions at all, throw them in the chat. I'd be happy to answer those. So the definition and classification. So we kind of talk about upper GI bleed, lower GI bleed, but what does this even mean? How do we even delineate upper and lower GI bleed? So if you guys remember your anatomy, obviously here's the esophagus here. We know that to the right runs the IVC, the inferior vena cava, as well as the aorta here and some of its branches. Here's what we're going to consider basically is this part here, right here, and it's called the ligament of Treitz. And that's kind of the boundary that we look for when we're trying to decide upper or lower GI bleed. And the way we do that is by saying, okay, ligament of Treitz, anything proximal, meaning before the ligament of Treitz, that's an upper GI bleed. Anything kind of distal to the ligament of Treitz is called a lower GI bleed. And so as you can see, stomach, duodenum kind of encompasses that. Esophagus, obviously, if it's a nosebleed, that's proximal. And then the things that you don't really see in this picture, lower GI bleed, we're going to consider the anus, the rectum, the transverse colon, ascending colon, descending colon. the small intestine, all of that stuff for low GI bleeds also. So we kind of talked about the etiology and the risk factors. We talked about NSAIDs. We talked about aspirin that can also inhibit prostaglandin production. But what we haven't talked about just yet is something that also causes peptic ulcer disease, and that's H. pylori. Somebody tell me, is H. pylori a bacteria or is that a virus? Good, perfect. It is a bacteria. It's a little gram-negative bacteria. It kind of hangs out in your mucosal surfaces, and that's what can cause a lot of acid reflux. And so the way we test for that is what we do is we give this really acidic drink, and we have the patient drink it, and then they do a breath test where they blow out what they tested, and you're testing for the H. pylori with that breath test. That's kind of the most common way to do it. We can also test for H. pylori based on serology, so we're looking for antibodies, but that's a little less specific, because if the antibodies are positive, that doesn't tell us if they still have it, because they could have cleared the bacteria and they're still going to be positive for the antibody. The other ways is we can test for the antigen in the stool as well. And then gastritis, two things we want to consider. As I kind of mentioned before, cocaine, it can cause little hemorrhages in the stomach. The other thing is Zollinger-Ellison syndrome. And that's basically a gastrinoma. That's a tumor that can make gastrin, which causes ulcers. And the way you see this is a patient with multiple different ulcers. Usually if you see an ulcer, you might see one or two, but these people, you know, have numerous ulcers throughout their GI tract. So that might tip you off that, okay, maybe there's something else going on here. Varices, we talked about that with cirrhosis and portal hypertension, those people of whom are alcoholics. We talked about Mallory-Weiss and Borja. These are people who are chronic, career vomiters. These are people who are alcoholics, can also get this, bulimics, stuff like that, people who are vomiting often. Okay, and here is a little cartoon. And this kind of shows all of those different causes that really can cause GI bleeding. So if we start here at the beginning, and by the beginning I mean most proximally up here, a Mallory-Weiss tear, that's what I was telling you, is that superficial tear of the esophageal mucosa. It's usually self-limiting. Usually by the time you figure out that it is that, it stopped bleeding by itself. Here's the gastritis that can be caused because of cocaine. Here's an ulcer, and then also a duodenal ulcer, and that's primarily what our patient had today. Other than that, when we head down into the small intestine, we can talk about ischemic bowel disease. If we don't get blood to that part of the intestine, it can necrose and slough off and cause bleeding. Intussusception. As you can kind of see by the cartoon here, what happens is one part of the intestine kind of telescopes into the other part, and that can cause part of it to lose blood flow and correspondingly bleed and die as well. There's also a Meckel's diverticulum. That's a little diverticulum that often happens in kids that can bleed. Angiodysplasia, which is an abnormal blood vessel on the colon. And then when we get down here, we talk about diverticulosis, we can talk about hemorrhoids, and also cancer too. And a big part that I didn't talk about tonight, but it's really important to exclude and to rule out, is when you have an older patient of whom has a microcytic anemia or any sort of anemia where they're bleeding rectally, you want to get them for a colonoscopy if they haven't had one, to rule out colon cancer. Okay, so that's it for that little cartoon there. If I'm not mistaken, that is one of the last slides. Okay, so here's a picture. We kind of talked about esophageal varices. And so the picture on the left here, those are those engorged vessels. And this is on a EGD, an upper endoscopy, where we're sticking a camera, we sedate the patient, we're sticking a camera in through their esophagus, and we're looking at their esophageal mucosa. Here we see these varices, and they're engorged with blood. And the problem here is sometimes these can rupture and bleed, and they bleed like crazy. And so it's so important to manage this and manage it meticulously and quickly, because it is an emergency. On the right here, what we see is you can kind of see this black part here, and this is when these are banded. And what we do is we kind of band them so that they don't have the opportunity to bleed. And that's an important intervention, and that's something that your GI friends will do for you. Or if you were the GI friend, then you're going to do that for your internal medicine friends. Okay, here's another cartoon. This is an artist rendition of Mallory Weiss tear. So this is kind of that tear in the upper esophageal mucosa, and it's pretty self-limiting. And when we talk about Boerhaave syndrome, that's what I was talking about. It's a transmural tear of this esophageal mucosa, and it causes subcutaneous emphysema. And that's when you press on that chest and you hear that crunch. And that's also an emergency. So a lot of these times with these GI bleeds, you know, you're not doing everything slowly. You're definitely being quick about this and really acting quickly in order to help this patient. Okay, so in terms of the pathology for this one, the things that we're going to look for upper GI bleeds is hypovolemia. So people who have dropped their blood volume, hypo meaning low, vol meaning volume. They've dropped their blood volume. That means they've lost fluid somehow. This patient has lost blood. Hypotension, as we really have seen with this patient ourselves, and the tachycardia, because they're compensating for that low blood volume. They might have abdominal pain, depending on where it's at. It could be in many different places. Pallor, so we're looking at their anterior rim, they might have pallor. The other thing is nasogastric lavage. So we're sticking down the nasogastric tube and we're looking to see what's in the stomach. And here's where we're talking about that coffee ground emesis. That could also signify an upper GI bleed source. In terms of the labs, we could have, you know, anemia, as we saw, so low H&H, hemoglobin and hematocrit, elevated BUN and creatinine because of that urea source. And then in terms of the treatment, what we want to do is transfuse if their hemoglobin is less than 8. Sometimes if they're sicker or have other comorbidities, such as having heart failure or any sort of coronary artery disease, we start to transfuse at a higher value, such as 8 grams per deciliter. NG lavage can, you know, much as it's the diagnostic step, it could also be a treatment, because putting in that saline and lavaging out the stomach may help the source stop bleeding. Your GI friends, they'll help you out with the EGD, so the camera through your esophagus, or the colonoscopy, the camera through the rectum to look at the colon, the ascending, transcending, and descending colon. Other than that, as I kind of alluded to before, we might contact our friends in surgery. If there's pneumoperitoneum or ongoing bleeding. Pneumoperitoneum meaning there's air in the belly. That's definitely a surgical emergency. That's called peritonitis, and we want to get that fixed quickly because they can get sick really quick. All right, so that is my sources. Mostly a lot of images, but what questions do you guys have for me? You can always unmute yourself and talk to me. You can throw your questions in the chat. If you don't have any questions, feel free to sign off. But I'm here to talk to anybody. I'll stay on for a little while and kind of talk to you if anybody has any questions or anything. If you have any questions and you want to put them in the chat, I'll respond to those as well. Thank you guys for coming to this. We're going to try to do these at least once monthly. And hopefully this was helpful for you guys. I know it's hard right now. I can't imagine being pre-med students and not able to sort of be involved with something that you're passionate about. So hang in there. Hopefully we sort of see a light at the end of the tunnel in terms of this. I hope this was helpful. Thanks everybody for coming. Let me know if you have any questions. You can always reach out to me with any questions or anything on the Premed app as well. I respond to messages in terms of that also. Oh, thank you. One of the best virtual shadowing sessions. I appreciate that. I hope you guys come out to our next one as well. Kind of stay tuned for that one. And if you guys have any topics that you're interested in, feel free to send those in. We're happy to sort of accommodate those things as well. I'll stay on for a few minutes. If you guys have any questions at all, feel free to stay on and ask me any questions, okay?